He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Hey folks, thanks for joining us. It's Stay Off My Operating Table with Dr. Philip Ovadia, and we have joining us today one of my most favorite guests, a frequent guest, and frankly, just a very entertaining guest, Dr. William Davis. Bill, thanks for joining us.
Glad to be here, guys.
Bill?
Yep, great to
it's your show. I'm going to shut up and just enjoy what happens here.
Sounds good. And it's always enjoyable having Dr. Davis back on the show. Looking forward to discussing some of the stuff he's been up to. He has a new book coming out that we certainly want to get into. I guess we should always start with the obligatory. If someone's been living under some rock somewhere and hasn't come across you in your work yet, Bill, maybe just give a little bit of the background, where you started and in traditional medicine and how you kind of found your way out of it.
So you and I would have, had we been in the same institution, would have tangled with each other. You as a thoracic surgeon, me as a cardiologist. And so I spent my first many years doing the things that you're very familiar with: angioplasty, stent implantation, all those kinds of things. But my mom died of sudden cardiac death about 4 months after her successful 2-vessel coronary angioplasty. And she lived in New Jersey at the time. I just moved to Milwaukee. They brought me in to set up some of the new technologies. This is the 1990s, the Wild West of a lot of the cardiovascular technology. But it became clear that, and I know you know this well, that delivering a treatment for heart disease in a cath lab, in an operating room, there's a time and place. But it means that the majority of people will die at home, en route.
Yes, folks, this is recorded in an actual home, in an office, not a sound studio.
So ideally, you identify people at risk for heart disease, like my mom, months, years ahead of time. And of course, the standard way to do that is to use cholesterol testing, which we all know is nonsense. It should have been abandoned 30, 40, 50 years ago. It's outdated. There's far better ways to gauge risk for future heart disease. This was true 30 years ago. Back then, the most reliable way to identify risk for cardiovascular events like heart attack, sudden cardiac death, the development of symptoms, of course, like angina, that signal need for such things as bypass surgery, stent implantation, etc. The only way back then was to do a CT heart scan that generates a coronary calcium score. That was true 30 some years ago. It remains true, largely true today. It's a very good test. People say, but we don't want to know about hard plaque. We want to know about soft plaque. Think of calcium as an index of total plaque. That's what my friend John Rumberger proved 35, 40 years ago when he was at Mayo Clinic, when he did an autopsy study, and he showed that people who died from a variety of causes, sudden cardiac death, cancer, old age, car accidents, and when they looked at their coronary arteries, it became clear that calcium, through all people, regardless of age or sex or cause of death, calcium occupied 20% of total atherosclerotic plaque volume. Not soft plaque, not hard plaque, total plaque. And that's
Okay, hold on. Remember, I'm not medical, so interpret that for us English speakers.
Okay, got it, Jack. So it's the stuff that accumulates in arteries, that blocks arteries, that more commonly ruptures and causes heart attack or sudden cardiac death. It's the stuff that Dr. Ovadia bypasses when he puts bypass grafts in. It's the stuff that we would stent in the cath lab or deal with in some other technology.
So it's the cardiac calcium that is implicated in 20% of all these cases. Did I get that right?
Easy way to think, Jack. If you had, say, 2 cubic millimeters of calcium, you have 10 cubic millimeters of total atherosclerotic plaque. Back then, so I brought a facility to Milwaukee, Wisconsin, where I was at the time. And back then, people would say, we don't care about hard plaque, or we just want to know how much blockage there is, which is an old-fashioned old-fashioned notion. It's this idea that the only time coronary disease threatens you is if it blocks flow. That's not true. The majority of cardiovascular events, of course, has nothing to do with progressive worsening of a blockage. It has to do with the sudden rupture of something that most would regard as a minor plaque. Let's say something that looks like a minor plaque, looks like nothing, maybe 30% reduction in diameter at some point in an artery, and it erupts. It's like a little volcano or a pimple. And when the underlying tissues get exposed to flowing blood, it causes blood clot formation. And that's why it's very difficult to predict looking at an angiogram. Something Dr. Avedi does all the time, looks at angiograms to know where he put the bypass grafts. But you can't pick out which plaque of the usually dozens of plaques one person can have. You can't say that one's going to rupture in 6 months. There's no way to do that. And so what the coronary calcium score did was it gave you an index of total lengthwise atherosclerotic plaque and would tell you it was a crystal ball. So let's say somebody had a score of 400 at, let's say, 52 years old as a guy. You know that he's going to have a heart attack, he's going to die, he's going to need a procedure, typically within about 6, 7, 8 years, something like that. It tells you what's coming ahead. And this is held true over and over again in so many, literally dozens of human clinical trials. Well, what do you do about it? Back then, we would say, okay, take a baby aspirin and high dose Lipitor to reduce cholesterol and cut your saturated fat and take a beta blocker and those kinds of conventional things. To what my colleagues to this day still call optimal medical therapy. We help publish these data. If your score is 400 and you do nothing, which is not smart, what's the score going to be a year later? 25% higher. So 400, 500, another year, 625. With each increase, you're closer to dying, heart attack, etc. What if you go on a baby aspirin, low-fat diet, Lipitor, high dose, cut the fat, exercise program, beta blocker? How fast will that plaque grow? 25% per year has zero impact on that measure.
Absolutely no impact.
And so what do you do? At the street level, we all live with other people, neighbors, friends, patients, and they're all freaking out because their scores are going up. Of course, Dr. Avedi will tell you, my colleagues will say, we'll do the real test. We'll do a heart catheterization, see if you need preventive stent implantation or bypass surgery, which of course is absurd. We now know with good evidence that does not provide benefit to somebody who's going to work, riding their bike, swimming, etc., with no symptoms. So what do you do with all these people freaking out and terrified? Rightly, it took a number of years of trial and error, looking at the science, zigzagging, and it taught us a whole bunch of new lessons. For instance, adding vitamin D. So scores were going up 25% per year. We improved diet, did some basic things like omega-3 fatty acids, slowed it maybe to 8 or 11% per year. So it did have an impact. Adding vitamin D was the first time I saw scores plummet. Scores of 700 calcium scores would drop to 425 or something like that. So over the years, it gave us a tracking tool to make it better and better. And one of the lessons learned also was the powerful factor that small LDL particles were. VLDL and small LDL, not LDL cholesterol, but small LDL particles, small low density lipoprotein particles. And so people would come in with their high heart scan scores, or they survived a heart attack, or they had a bypass surgery 3 years ago and didn't want to have to go through it again. We would do their lipoprotein testing, not their cholesterol testing, but their lipoprotein testing.
This is a different test. I should probably know this, but that's news to me.
So it's the test, Jack, that should have been done the last 40 years. I've been doing it for 35 years.
Rather than the cholesterol test.
I tell people, here's what you do with cholesterol testing. Take a big, thick, black magic marker and cross the values out. They're nonsense. They were meant to be indirect markers for the lipoproteins that cause coronary disease. You and I can measure the lipoproteins. It's been around for decades. And you'll see over and over again, the driving factor is small LDL particles. That is, particles that are very small. They're able to infiltrate the walls of arteries. They're much more prone to such phenomena as oxidation and glycation. They're much more long-lived. They persist about 5 to 7 days in the bloodstream as compared to 24 hours of a large LDL particle. So this science, remarkably, was sorted out over 30 years ago by people like Dr. Ron Krause at University of California, Berkeley, at University of Toronto, Hopkins, University of Texas System. They had worked this out a long time ago. What are the things that cause small LDL particles? Consumption of wheat, grains, and sugars. Anything with amylopectin A from wheat and grains or sugars, amplified by insulin resistance and inflammation, which are now ubiquitous in our world. So someone would come in with a, let's say, coronary calcium score of 900 or had bypass surgery or whatever. You get their lipoproteins, and small LDL would be something like 2,400 nanomoles per liter, particle count per volume. You ask them to go wheat and grain free, introduce vitamin D, omega-3 fatty acids, some other basic things. Small LDL would be 0 or some other very low number. It wouldn't be 10% better. It wouldn't be 15. It would be obliterated. But that's when people said things like, you didn't tell me I'd lose 8 inches off my waist. You didn't tell me that my fatty liver would go away. You didn't tell me that my rheumatoid arthritis would be much better. I could stop 2 drugs. That my blood pressure would drop so much I had to stop 2 antihypertensive drugs. And that's when it became clear that this was the birth of the wheat belly story. That is the idea that wheat and grains, what we call wheat and grains, because it's not the stuff that grew wild. It's this thing changed by agribusiness and genetics research. And that began the wheat belly whole saga. But it also led to this idea that people have enormous power to address their own health, and you often don't need the doctor. That is, you don't need the doctor to dispense a prescription for Lipitor. You don't need to. A lot of this could be done on their own. So it led to some other books like Undoctored, which got me blacklisted from all major media in 2015. But it also led to this idea that there were things wrong with the microbiome and that basic efforts like probiotics were grotesquely inadequate and that more needed to be done.
So you just gave a master class in cardiology, and it all makes perfect sense. It's all well supported within the scientific literature. Certain, maybe very few members within the cardiac health community have patients that are doing this with great success. And yet, if you show up as we're recording this right next week at the American Heart Association meeting, and you talk about these things, 99.5 out of each 100 cardiologists that are there are going to say, this is ridiculous. You're a quack. It's all lies. It doesn't work. We know the answer to heart disease. Just take your statins. And if statins aren't enough, take your PCSK9 inhibitor so we can try and make your LDL cholesterol level 0. And that's the true way that we're going to cure heart disease. Now, you've been around a long time. I've been around a little bit less time. I've told the story before that when I was choosing my surgical specialty, I was deciding what to go into. And I told my mentors I wanted to go into heart surgery. They said that is the absolute last field you should go into because there's going to be nothing for you to do in 20 years. And here we are 25 plus years later, still busier than ever. There's a shortage of heart surgeons in this country. There aren't enough heart surgeons to do all the heart surgery that needs to be done. Why is the cardiology community so resistant to these ideas? Why hasn't things changed? And just basic things like you talked about, right? Get a CAC scan so you can see the disease, and then follow the CAC scan so you can see the progression of the disease. And yet even that basic idea is basically is not considered at all within the standard cardiology community.
Sad to say, it's about money. It's always been about money. That is, there's too much money to be made by being indifferent. It's not an evil, it's not a purposeful thing. It's this kind of programmed indifference. So if we talk to the scientists who do this, they'll say, of course, it's quite clear. It's liver de novo lipogenesis that converts the amylopectin A of wheat and grains and sugar and like glucose and fructose. The liver converts those sugars to triglycerides. That process is called liver de novo lipogenesis. This is well worked out over decades. That's expressed as very low density VLDL particles in the bloodstream. You'll see on a lipid panel, by the way, as high triglycerides, not as VLDL. They don't report VLDL, they report triglycerides. But you'll see, so because triglycerides track VLDL very well, you'll see higher triglycerides, 180 milligrams, 240, something like that. Ideal, by the way, 60 milligrams or less. Those VLDL particles interact with LDL particles, contribute those triglycerides to the LDL particle. That LDL particle goes through a series of enzymatic transformations that convert it to a small LDL particle. No one has to remember that, but the problem here is it begins, the input is grains and sugars, though amplified by the ubiquitous processes of insulin resistance, which is most of the US population now, and inflammation, and more recently it's become clear that portal vein endotoxemia is a major driver also, meaning, so it's the portal venous system that drains the gastrointestinal tract. That is, the small intestine, the colon drains not into the systemic venous system, but into the portal venous system. And that drains directly to the liver. So your poor liver takes a beating. It's hammered by bacterial breakdown products. But this becomes especially an issue if the small intestine is involved. In other words, bacteria are supposed to be in the colon, in the far distal part of your gastrointestinal tract, the 4 to 5 feet of your colon. Unfortunately, modern people, we've been so miserably overexposed to antibiotics, to food additives like preservatives, emulsifying agents, other factors, herbicides, pesticide residues in food. All these things have disrupted the composition of microbes in the colon, and the end result has been overproliferation of fecal microbes, such as E. coli, Klebsiella, Salmonella, Campylobacter. And those fecal microbes, once they overproliferate, ascend into 24 feet of small intestine. The small intestine is not equipped to deal with that. It's very permeable by design because that's where we're supposed to absorb fatty acids, amino acids, vitamins, minerals. But when you have trillions of fecal microbial species colonizing the small intestine, of course, these microbes live for only a few hours. When they die, they shed their components, especially something called endotoxin, into the intestines that then gains entry into the portal venous system, goes to the liver, beats the heck out of your liver, amplifies that process of de novo lipogenesis that creates VLDL, then small LDL. And then that endotoxin then enters the systemic.
Oh, wait, you just said something that I don't think I'd heard before. Did I hear you say that the overuse of antibiotics also contributes to the excess proliferation of the lipid proteins, the VLDL and LDL that cause that? Did I hear that connection right?
Yeah, Jack. Yeah. So in the US, 650,000 prescriptions are written for antibiotics every day. Most people by age 40 have taken 30 rounds of antibiotics. You've seen these people. Oh, I've been on antibiotics for 2 years for Lyme disease. I've been on antibiotics for 3 years for my acne. Or I had to take antibiotics for my viral upper respiratory infection. So there's been massive, worse in the US than elsewhere, but there's been massive overexposure to antibiotics and other factors. And that has disrupted the gastrointestinal microbiome. So we have, with good evidence.
And that is implicated with the development of heart disease.
Yes. So the infestation, the colonization of the small intestine, 24 feet of small intestine. So it's not as wide, but it's much longer than the colon. And it drains into the bloodstream. And when that endotoxin enters the bloodstream, that's called endotoxemia. Dr. Ovadia has seen this as sepsis in the hospital, right? People have a urinary tract infection because they had a Foley catheter in, and it became pyelonephritis, kidney infection. Then it became sepsis. And the person goes into shock. They have to go on drugs to support blood pressure drugs. They may get intubated, put on a ventilator because they have respiratory failure. Sometimes they go into kidney failure, have to go on dialysis. They're sedated because it's misery being on a ventilator. So that's sepsis. And that's when endotoxemia is more than 100-fold greater than normal. We know that endotoxemia in the setting of sepsis is often fatal. It's very bad. These are critically ill people in the ICU. The an endotoxemia that occurs when you have small intestinal infestation by fecal microbes, small intestinal bacterial overgrowth, or we say
Right.
SIBO, SIBO.
Right.
The
Remember
rise in endotoxemia in the systemic circulation, it's much higher in the portal venous system, battering your liver, but in the systemic circulation, it's only about 200 to 400% higher. But one of the problems we have is the method to measure blood levels of endotoxin is flawed and it tends to underestimate the severity. And that's because it's an antibody test and because there's so many microbes involved in this process that the antibody test is only identifies the endotoxin of select species like E. coli and Klebsiella. And it's not clinically available, unfortunately, by the way. It remains a research tool. We have a study going on right now where we're quantifying endotoxemia by measuring, but it tends to underestimate. I think we'll have it one of these days and we can actually measure the degree of endotoxemia. But that is, it's become clear, a major driver of coronary disease, especially coronary plaque rupture. And that's the process that leads to heart attack, sudden cardiac death. It's also a driver of recurrences of atrial fibrillation and of congestive heart failure. In other words,
I've got to follow up on this just because I came of age. I was a kid around the time that every childhood disease was treated with around antibiotics. I have zero doubt that I was grossly antibioticed as a child. And I've just never heard that particular circumstance, which is very common, especially for people around my age, being connected with, directly connected, logical chain, chemical chain between too much antibiotics and the development of the problems that lead directly to a heart attack. So I don't mean to steal your thunder, but I want to jump in. So is there is there something here that could be done if you're one of those people who was over antibiotic, I don't know if that's the right word or not. What the heck do we do?
and Jack, it's half the US population.
Yeah, I was going to say, I'm not alone.
No, I used to think it was rare until two things happened that showed, oh no, it's not rare. This is everywhere. One was the availability of a consumer device. It's called the AIRE device, AIRE. This is the original. It measures hydrogen gas. Microbes in the GI tract produce hydrogen gas, but you cannot. This is the more recent device, measures hydrogen gas and methane. That is bacterial byproducts. So what these are, so you blow into it, talks to your smartphone, 0 to 10, tells you how much hydrogen gas. Now there's a little protocol you have to follow because it's all about the timing of release of hydrogen gas. But when this came out in 2018, I had people, and by the way, the inventor, Dr. Angus Short, very nice guy in Dublin, Ireland, he thought it was a device for people with irritable bowel syndrome to navigate a low FODMAPs diet. And so I called him. I said, Angus, that's not what you invented. I'm telling the inventor what he invented. I said, this is a mapping device you invented. He says, oh, I see now. He's an engineer. He's not a doc. And it's become clear this is a device to track or map where microbes are living. Are they in your stomach in duodenum and jejunum, way up high? Or are they in the colon where they're supposed to be? So it's all about timing when you consume something that microbes can convert to hydrogen gas. Well, I have a bunch of people testing thousands of it, and lo and behold, it's everywhere. And then I did this. If we look at the dozens of clinical studies already done over the last 15 or so years, asking this question, in condition blank, what proportion tests positive for SIBO? It'll be hydrogen gas testing, usually in a clinic or lab, sometimes with endoscopic aspirate of the duodenal or jejunal contents. Those are the ways I identify fecal microbes in the small intestine. In condition blank, what proportion tests positive for SIBO, for hydrogen gas? Let's put in the blank irritable bowel syndrome. There are 60 to 70 million Americans with irritable bowel syndrome. What proportion tests positive? It varies from study to study, but about 31%. That's about 18 to 20 million people right there. How about in obesity? There's 110 million obese Americans. What proportion will test positive? Likewise varies, but about 50%. So that's about 55 million people right there.
Wow.
How about rheumatoid arthritis, fibromyalgia, restless leg syndrome, sleep apnea, neurodegenerative disorders like Parkinson's and Alzheimer's, dementia? In other words, of course, there's some overlap, but if you add up the numbers, you'll see you easily exceed 150 million people that have this process of the infestation of the small intestine. And it is, among many other things, a cardiovascular risk factor, as well as a driver of weight gain, especially in abdominal fat, skin rashes, neurodegenerative disorders, diabetes, higher blood glucose, hypertension. In other words, all the things we thought we knew something about, we have to reconsider in light of the contribution of this process of a permeable small intestine that's draining fecal microbial byproducts into the bloodstream, endotoxemia. Now, and answer your question, Jack, what do you do about it? If you go to the gastroenterologist, most will say, Jack, there's nothing wrong with you. We didn't see anything on your colonoscopy. Get out of my office. Or did you consult Dr. Google again? Right?
Yeah.
Because they have not caught up with the science, even though the science has been abundant. SIBO was identified 30 years ago for the first time. Or they might say, the better informed one will say this: here's a prescription for rifaximin, an antibiotic. And it does work. It's about 55 to 70% effective. But the problem is there's no mention of how you got this, how to prevent recurrences, which are the rule. And of course, it's an antibiotic. Antibiotics got us here. Do we really believe an antibiotic is part of the solution? So one of the things I did was this: ask this question. So if let's say you have this problem, you've got maybe an autoimmune condition, maybe you're overweight, you're pre-diabetic, whatever, and you take a commercial probiotic off the shelf. What's the likelihood this SIBO process will go away? Close to zero. It might reduce some bloating, but it's not going to get rid of 24 feet of trillions of microbes in your small intestine. So I asked this question: what if we chose species that are known to colonize the small intestine, which is unusual? Most do not. So what if we choose species that are known to colonize the small intestine and produce what are called bacteriocins? These are natural antibiotics that kill fecal microbes. So I chose three. I chose a strain of Lactobacillus reuteri, a strain of Lactobacillus gasseri, and the most recent version of this, a strain of Bacillus subtilis. These are three microbes that either colonize, or in the case of subtilis, germinates, it's a spore, in the small intestine, and then produce a bunch of bacteriocins. So far, this has been spectacularly effective, far beyond my expectations. I have 2 clinical trials I'm trying to get funded: a pilot study, then a randomized placebo-controlled study, or at least a non-inferiority study versus rifaximin. We'll try to get that done, but as we know, we're not pharma. We don't have the billions of dollars that the pharmaceutical industry has, because they rip people off for lots of money. So we have to scrape by in our clinical trials, but we will validate it. But in the meantime, I tell people, well, you don't have to wait for that. If the solution is something that looks and smells like yogurt that you make in your kitchen, and has all kinds of other spectacular benefits on skin. Ladies go berserk for skin. Musculature, the immune system, libido, testosterone. Why wait? It's not a drug. It's a consortium of microbes chosen for those specific purposes. And so far, it has exceeded all expectations. I call it SIBO yogurt on the way, which I kind of regret, because it gives people the impression that it's only useful in that setting for SIBO.
Right.
It's what I should have called it is restoration of Keystone microbe yogurt, but that's not very catchy.
Yeah, not a catchy name. Okay, I didn't mean to throw you off track there, but I was just kind of stunned by the connection between overprescription of antibiotics and heart disease. And maybe I mean, for all I know, I've been having people tell me that now for months or years, but it's the first time it connected.
I wish we were 25 again, because just exploring scientifically the connection between the gastrointestinal microbiome and its disruption with cardiovascular disease, it's yielding to exploration to science, but there's so much here to know more, because I believe that the microbiome via endotoxemia. In other words, I emphasize that endotoxemia because it tells us how microbes in the GI tract can exert effects everywhere in the body, whether it's brain, skin, joint, heart. But in the heart, I think we're going to find, and this event is preliminary, but it's coming out, that endotoxemia is a major player in congestive heart failure, whether the cause is a cardiomyopathy or a coronary event, in arrhythmias, especially atrial fibrillation, not the original cause of atrial fibrillation, but a cause for recurrences of atrial fibrillation. Maybe for other arrhythmias, maybe ventricular arrhythmias, maybe even supraventricular arrhythmias, for, of course, coronary disease. In other words, if we're giving people drugs to block recurrences of atrial fibrillation, like beta blockers and propafenone and all those nasty drugs, or putting in devices or ablations, what if a better solution would be just to address the microbiome? It won't get rid of the atrial fibrosis that drives AFib, but it could remove the near-term triggers for recurrences. And so I'm very excited what we can accomplish for cardiovascular disease, but it's one of the neglected poor cousins in the microbiome world. There's a lot of attention being paid to other things. Like the vaginal microbiome, by the way, which is huge. The vaginal microbiome is yielding to all kinds of really cool science that I've been paying a lot of attention to, because my daughter-in-law just delivered her third child. And this is a woman who has no shortage of resources. She's got an endocrinologist, a rheumatologist, a primary care doc, a functional medicine, a gastroenterologist, and a bunch of other specialists. No one mentioned anything about the microbiome, even though the gastrointestinal and the vaginal microbiome are critical players in pregnancy, delivery, and the early health of an infant. No one mentioned, for instance, the power of Bifidobacterium infantis for the neurological maturation of a newborn, or of Lactobacillus.
That's a bacterium, I guess.
I'm sorry, that's a bacterium. That's right, Jack. Yeah. Or Lactobacillus crispatus, the dominant, very exciting stuff. There's work from Loyola University, which is like 15 miles from where I'm sitting right now. They've done some very elegant work in the vaginal microbiome, showing that Lactobacillus crispatus is critical for a woman's health in reproductive years. It protects her from STDs, from vaginal infections like Candida and bacterial infections, protects a woman from repeated urinary tract infections. Incontinence, it protects her from incontinence, and protects an older woman from vaginal atrophy, dryness, discharge, etc. In other words, and a lot of ladies have lost it because it's a lactobacillus species like Rhodori gasseri. And the lactobacilli are very susceptible to common antibiotics. So it's an across-the-board decimation of lactobacillus species, and the consequences could be thinner skin and wrinkles. It could be accelerated loss of musculature as we age. It could be a reduction in testosterone in older guys. It could be vaginal atrophy in older ladies. But you can see that the discovery of all these impacts of various species of microbes that we've all lost. It takes one round of antibiotics to lose hundreds, literally hundreds of beneficial species in the gastrointestinal and other microbiomes like vaginal, skin, brain, airway, bladder, prostate. The prostate science is just getting started, but it's getting very interesting. Prostate disease is probably a disease of the microbiome, as is hyperuricemia and gout, calcium oxalate kidney stones, pancreatic cancer, colon cancer. These are all diseases of the microbiome. And by the way, colon cancer is looking like a disease of the oral microbiome.
Huh.
You know, what's interesting about all this, right, is how it all comes together, because you can come at it from many different directions, right? You can look at it from the insulin resistance, the metabolic kind of disease that obviously is so prominent. And you can look at its impact on, for instance, neuropsychiatric conditions, right? This whole growing field of metabolic psychiatry. And it all ends up kind of circling through the gut, right? And just the basic facts that most doctors, right, forget, right? That there is a direct connection between the gut and the heart, right? This thing called the thoracic duct that leads right there. And then you have the nerve, right? The vagus nerve that's running, right? Between your gut and your heart and then up to your brain. And yet we fail to consider the importance of all these connections. And on one level, it should be so obvious. And yet it's so hard for most clinicians, most physicians these days to see or to consider or to think about.
And the things we all need to do to rebuild this broken thing called the microbiome, whether it's gastrointestinal, vaginal, skin, or whatever, those are still works in progress. It is clear that that thing I mentioned, the SIBO yogurt formulation, the poorly named SIBO, that is at least a good start. I don't know how necessary that is long term. And because long term, the goal is to restore diversity in all those microbiome locations. And you can restore diversity, not so much with the restoration of keystone species, that's a start, but simple things like fermented foods, like sauerkraut and fermented pickles and veggies you ferment on your kitchen counter. Yogurt, yes, but not the stuff in the store. The stuff in the store is this thing that looks like yogurt. It's not. The process of fermentation is so brief. So when we ferment, for instance, ferment Lactobacillus rhodori, as you guys recall, microbes don't have sex. There's no male and female microbes. They just reproduce asexually. So one microbe becomes two becomes four, and they all reproduce at different rates. Lactobacillus rhodori doubles every 3 hours at human body temperature. And so if you're in a commercial yogurt making factory, you're not going to ferment rhodori, by the way. They're fermenting other microbes. They're fermenting Lactobacillus bulgaricus and Streptococcus thermophilus, traditional yogurt microbes. We're going to ferment human microbes, by the way. I was in a beer making store one time and I'm asking the guy, so tell me what you're fermenting. I said, we'll use Saccharomyces cerevisiae for our beers, sometimes Lactobacillus brevis for malt. And they said, what are you fermenting? I said, we're fermenting human microbes. And these beer making guys were horrified. They were horrified that we were fermenting, because it never occurred to me. That's what we're doing. We're fermenting human microbes that were originally sourced maybe from stool or from breast milk or the vagina or the skin. But that's what we're doing. We're storing microbes that are suited to the human environment. But how to do this long term, that's a work in progress. But fermented foods are clearly based on the work of the Sonnenbergs at Stanford, Erica and Justin. They do very elegant work. They showed in a very exhaustive study that it's the consumption of fermented foods that is key to restoring microbial diversity, as well as fibers. That is, fibers in foods like legumes, chickpeas, black beans, white beans, peas, onions, garlic, shallots, other root vegetables. That is also part of the solution for generating diversity. And kind of retracing our steps back from all the mistakes we've made ever since penicillin came out in 1928. Or was it discovered, I should say, 1928, but not commercialized until about a decade later.
How much do you think this comes down to removing the things that are destroying our microbiome? We mentioned things like the pesticides, the herbicides, the wheat, the gluten, the highly processed foods in general. I think most of us would agree on these days, versus reintroducing these, right? Because we have a carnivore community, right, that never eats fiber, essentially, maybe doesn't have a lot of these things that you mentioned as being beneficial for reintroducing the positive, the microbes that we're looking for, but it does a really good job at eliminating most of this toxic stuff that has been impairing our microbiome to start with. So how do you look at that balance, and what do you think carnivore is a good approach? What, if not, what do you think maybe needs to be modified for most people?
It's probably impossible to live entirely clean. It's like trying to avoid microplastics. Sadly, good luck with that, right? It's in your toothbrush, it's in your water, it's in the air, it's in the dust in your house. It becomes very difficult. So people should try, of course. But it becomes very difficult to really truly lead a clean life in this world. We've botched it up so badly. All we can do is reduce or minimize our exposures. What if antibiotics were never invented and we just had exposure to such things as preservatives in food and other things? How bad would it be? No one knows, of course. No one has a time machine and could conduct that randomized trial. But it's probably a combination of all those things because we know. For instance, preservatives in food are meant to be antimicrobial to block such things as mold growth in your food, but it does so in your gastrointestinal tract also. Likewise, emulsifying agents. So as when someone has a colonoscopy, they use Miralax as the prep, which is a very potent emulsifying agent, as is polysorbate 80 and carboxymethylcellulose in your ice cream or in your salad dressing or in pickles. What emulsifying agents do is they dissolve the mucus barrier. And the mucus barrier is very important for your protection. It's always being produced, but if you dissolve it, even for a few minutes or a few hours, as with Miralax, you've opened the door to that endotoxemia process. It also changes the microbial composition of the gastrointestinal tract. So it's hard to know. It's hard to say something like, what, 80% is due to antibiotics and 20% is due to chlorinated drinking water and preservatives. Yeah. It's hard, impossible to say, but it's probably all those things. Now, the science, one of the ironic things about what they call it, carnivore or ketogenic, they're all pretty much there's a lot of overlap, right? So as you guys recall, the ketogenic diet has a century of research. It's the best studied diet ever because it was discovered accidentally that children with intractable grand mal seizures would have about a 50% reduction in the frequency of their seizures with a ketogenic diet. And the original conception of a ketogenic diet had a lot of corn oil in it. That has since been replaced by medium-chain triglycerides, coconut oil, and other oils. What happens to those children? This has been studied, about a dozen studies. They stop growing. They develop calcium oxalate kidney stones, about 8% of them do. And these are children. Many of them develop osteoporosis in their teens. Some die of sudden cardiac death, unclear why. They have constipation. There's a marked reduction in colonic diversity of microbes. There's a change in the microbial composition of their GI tracts. But specifically, so reduction in diversity, there's an odd phenomenon that occurs. So when you deprive your body of fibers, whether it's carnivorous or ketogenic, many species die. So imagine Jack tied his dog up in the backyard and forgot to feed him for 5 days. You come back, dog's going to be dead. If you don't feed something, it dies. If you don't feed the microbes, they die. Or they're at least markedly reduced in numbers. The odd thing is there are a handful of species that can survive, such as Akkermansia muciniphila, mucus lover. And Akkermansia, when deprived of fibers, will turn to human mucus for food, because mucus is a polysaccharide. So Akkermansia will start to consume human mucus. That leads to colitis, an inflammation of the small intestinal wall. It leads to an increase in endotoxemia. It's an experience like this. Somebody says, I went carnivore, or I went ketogenic, and it was great. I lost 38 pounds, my triglycerides dropped, my blood pressure dropped, my waist shrunk by 8 inches. I feel great. About 18 months in, give or take, somebody says, I am now constipated. My triglycerides have gone back up, my HDL dropped, my small LDL went back up, my blood pressure is going back up, I'm having disrupted sleep, and that person has probably set themselves up for diverticular disease, colon cancer, ulcerative colitis, and metabolic distortions because they disrupted the gastrointestinal microbiome. And there's a whole bunch of reasons for that. There's a disruption of bile acid metabolism. There's deprivation of polyphenol-derived nutrients that have role in the microbiome. In other words, there's massive disruption of the microbiome. It's not a good idea to stay on you can do it for a few weeks, but longer than that, you start to develop these microbiome consequences.
But I guess I'd push back and say there are plenty of people who have done this long term with good success. And what's going on there? And what do you think are maybe some of the factors that allow some people to do this over the long term? Very strict, right? I know many people that have kind of advanced autoimmune disorders that any little bit of plant product, it kind of sets them off. And so they're pretty strict, and they seem to be maintaining great health decades into carnivore diets.
Of course, there's never been a randomized trial to track such things as dementia,
Yep.
colon cancer. So we're always kind of in the dark about that. But another thing to be aware of is all these food intolerances, like the ones you're talking about that people address with their carnivore diet. Or it could be FODMAPs intolerance, or it could be nightshades, it could be histamine containing foods, it could be oxalate containing foods, it could be lectins. These all go away with addressing the microbiome, and those are almost all SIBO. That if you test those people, they all have SIBO. If you address the SIBO, those food intolerances almost always, and of course, food intolerances are all modern phenomena. Our great grandmothers did not have any of these problems. If we told our great grandmothers, I can't eat eggplant, tomatoes, in fact, I have a list of only 7 foods I can eat safely because of those testing that people do, like the IgG testing. And she would say, "You're nuts. That's crazy. I ate all those things when I was alive." And so we're dealing. So I don't know why that happens. Maybe there's genetic variants. Maybe there's a microbiome. Maybe there are things that modify the microbiome that we're not aware of. But of course, we'll never know unless there's going to be. And of course, no one's going to do a randomized clinical trial to see if there's more colon cancer in 15 years.
Yeah, I mean, I think the good news is that your yogurt does fit within a carnivore diet. And I know many people have introduced it to get some of that kind of microbial diversity. And I do see an increasing focus on fermented foods. We had Bill Schindler on the program not too long ago, and he was talking about the magic, really, of fermented foods. And I think a lot of people are starting to recognize that's something, again, that ancestrally was a big part of our diets out of necessity, right? They had to figure out how to detoxify some of these foods, how to preserve some of these foods, and fermentation seemed to be a big part of that. And I think a lot of people are coming around to this concept of reintroducing fermented foods into the diet can have many positive effects. I think this brings us around to your new book, which we definitely wanted to mention, Superbody. As this gets released, the book will be released probably shortly after this episode in mid-December. I've been fortunate to get a preview copy of it and have found it a great, I would say, follow-up, build upon your other books, Wheat Belly and Super Gut. What led you to write the new one? What did you think was still unknown out there that you didn't have in your previous books?
Dr. Ovede, this is a book I couldn't have written even 5 years ago because the science in that space of time has advanced considerably, showing us, for instance, that any effort to reduce calorie intake, whether it's a low-calorie diet, or a bariatric procedure like lap band or gastric bypass, or a pharmaceutical like the popular GLP-1 agonists. GLP-1 agonists make you indifferent to food and it slows gastric emptying. So they're all variations on the same thing, reducing calorie intake. And we know now with good science, a lot of it from our own NIH, by the way, we know with good science, when you reduce calories, regardless of the method, you will lose weight, but 25% of that weight will be muscle. And when you lose muscle, we know now that basal metabolic rate, the rate at which your body burns calories, the work of living, breathing, digestion, etc., is reduced by about 25%. And it's reduced for all practical purposes permanently. And what that means is you will regain the weight. We saw this in the Biggest Loser study. That was an NIH-sponsored study, as you recall. So these are graduates of the 8th season of The Biggest Loser. And people lost huge amounts of weight. They felt great. They looked great at the end of the show. They had their basal metabolic rates measured, 27% lower, and repeated again 6 years after finishing the program. It still was 27% lower. And I think all but one had regained all the weight. Danny Cahill won the show. He got his $250,000 prize by losing 239 pounds over 7 months, which is extraordinary. But by the way, it tells us that this idea that they're lethargic and lazy, this was an extraordinary effort. He exercised 4 to 6 hours a day. When he left the show, he continued a 2 hour per day resistance exercise and aerobic training program and a very low calorie diet. He regained all the weight. And he'd go back to the annual reunion hosted by the producers, and he saw all the other graduates all regaining the weight. So when basal metabolic rate drops because of loss of muscle being the primary determinant of basal metabolic rate, you need fewer calories because your body thought you were starving, and it reduces burn rate to keep you alive. And so they regained the weight based on that. Another thing to know about is we now know with good confidence, based on several large databases, the NHANES database from the NIH, the EPIC Norfolk from Western Europe, the ASPRI database, and a bunch of others. In total, about 60,000+ people have been tracked for many years, 10 years and longer in some cases. What happens to people who lose weight? Largely by reducing calories. They die several years younger, despite the upfront benefits, right? That was what's so puzzling. People say, I lost weight, my cholesterol's better, my triglycerides are better, my blood pressure's better, and you die younger. Why would that be? No one's actually connected all the dots, but it's more than likely loss of muscle. So somebody pays $12,000, or maybe your wife pays $12,000 to take Wegovy or whatever. She loses 40 pounds. Of that 40 pounds, 10 pounds is muscle, 30 pounds fat. After a year, she stops it. Most people can't afford that forever. She regains 32 to 34 pounds of fat, very little muscle. She's now more likely to be pre-diabetic, type 2 diabetic, hypertensive, risk for coronary disease, dementia, breast cancer, others. She's now at higher risk than she was at the start, and she's accelerated her path to falls, fractures, frailty, loss of independence, and a premature death. This is what the FDA approved. Now, the good news, that's the bad news.
Yeah.
The good news is this focus on muscle is critical. You cannot allow loss of muscle, whether it's from aging or from weight loss. You want to track it. And there's a number of ways to track it, like a bioimpedance scale, a body fat scale. You can measure muscle and track it and rebuild it. You can take steps to rebuild muscle. But people hear things like weightlifting, a bunch of hours, or creatine. No, there's a lot of other things that someone can do. For instance, one of my philosophies is the best things for health are restoring things lacking in modern life. So Jack refuses to eat brain. He won't eat heart or pancreas anymore. So he's lacking collagen. So we all have been leading a collagen depleted diet. And collagen is a major player. It's a major structural protein, of course, is a major player in where muscle, how much muscle you have, and where fat is located. So restoring collagen is a big part of the answer. There's a whole bunch of things that we can do, but the whole philosophy is to restore things. Restoring lactobacillus reuteri, major player. In fact, I call reuteri via the hormone oxytocin the hormone of body shape and composition because it helps restore youthful musculature. It reduces abdominal visceral fat, reduces snacking behavior, hedonic eating. So there's a whole menu of things that we can do, but all driven by the same philosophy. Let's restore things that have been lacking in your life. Hyaluronic acid. Your wives will say, "Oh, don't tell me about hyaluronic acid. I pay $120 for an ounce and put it here." Not recognizing the real power of hyaluronic acid, this polysaccharide that's in brain and skin and other organs, when consumed orally, is a major fiber that increases dermal collagen, increases the synovial fluid in your joints, the lubricating fluid, increases the collagen in joint cartilage. It's the major ingredient in the glycocalyx of arteries. In other words, we've been leading a collagen and hyaluronic acid depleted lifestyle because of this nonsense of cut your fat, cut your saturated fat that caused most Americans to abandon consumption of organ meats and other animal sources. But therein lies at least part of the solution to regain control over what I call shape and body composition.
Okay, so I'm assuming because of Phil's question and because of just the fire hose of information that I've been trying to absorb here, that you lay it out in the new book, Superbody?
Yeah, so it's kind of a Bible of how to rebuild. In other words, the old idea was lose weight, right? We're going to move more, eat less,
Move more, eat
program for
less.
smaller portion size, exercise more, all that stuff. They're temporary fixes, long-term failures. Now, the most recent version, of course, is GLP-1 agonists, which I'm told by the attorneys that the class action suits have just started. That is, when you find out that your health is destroyed, it's going to be hard to prove that it causes premature death. That came from other evidence, but it's very likely we're going to see a big uptick in all kinds of diseases. We're going to see an uptick in disability, frailty, all that stuff, and premature death. The science has already been done. It's not, in other words, this is not us speculating. This is based on the existing science that tells us if you lose weight, so if you, particularly if you lost more than 10% of your body weight. So if a 180-pound woman loses 18 pounds, which is not that much, easily achieved, say with the GLP-1 agonist, you're likely to die probably around 3 years earlier than you should have. And those last few years are more likely to be with a walker, an assisted living, falls, hip fractures, those kinds of things. This is what all that money going into the pockets of the pharmaceutical industry is achieving.
Not surprised. Okay, the book is called Superbody. Dr. William Davis, thanks for being here. I always have such a good time chatting with you. I will confess, I struggle to hang on, but I also think I'm able to extract from these conversations at least the bits that make sense to me. I knew that I had been overfed antibiotics as a child and much more careful with it as an adult. But my God, I'd never heard the direct connection between antibiotics and heart disease. And that was pretty cool to hear that. That was really cool.
Thank you, guys. Keep on fighting the good fight.
Yeah, and you've been continued to do amazing pioneering work. I hope maybe one day we can walk into the American Heart Association meetings together and talk about these things and have people listen so that we really can make an impact on heart disease. Again, I hope one day that my mentor who told me not to go into heart surgery because heart disease has been cured will be right. It's just going to take a little bit longer, I think, than they expected because we got so distracted by what we thought were answers and weren't. But the pioneering work that you're doing, I think, is getting us in that direction, and we'll keep fighting the good fight.
I'll tell you a quick story to further entice you with this.
Yeah,
So
definitely.
It's pure anecdote. So proof of nothing. But nonetheless, so I had a friend who got an EKG and had a new left bundle branch block. And you'll know, Dr. Ove, that's bad news, right? Something very bad happened to her heart because she has a major short circuit and she's at risk for dying, having her heart rhythm stop altogether. They do an echocardiogram. Her ejection fraction, the strength of her main pumping chamber, is cut more than half. So her ejection fraction is about 25%. This is a healthy woman, right? And so they put her on all the usual drugs, the ACE inhibitors, the beta blockers, the anticoagulants. They're talking about either a biventricular pacemaker or a defibrillator, and pretty catastrophic stuff. I said to her, hey, listen, we know the heart is filled with receptors for oxytocin, the hormone oxytocin. We know that the oxytocin boost you get from some of these manipulations of the microbiome, especially restoration of lactobacillus species like rotari. We know that there's a marked increase in skeletal muscle. We know that with good confidence. Could it also happen with the myocardium, heart muscle? So I said, there's nothing to lose. You might get better skin out of it after all. She does it. She goes back to her cardiologist. He says, I don't know what happened, but your left bundle branch block is now gone. You know, that never happens. That never happens. So her left bundle branch block is gone, and her ejection fraction is now more towards 50 or 55%. Now, is that proof? Of course it's not. But I think it's a taste of things to come. That is, the power of the microbiome, in this case, of lactobacillus species via oxytocin and the gut-brain axis. I'm sorry, the heart-brain axis in this case, could be incredibly powerful.
Yeah,
Wow.
definitely. And we are seeing stories like this every day, right? And we're seeing diseases that you and I were taught were not reversible being reversed. And it just speaks to the power of changing some of your habits, right? And it can have major impact on life. Again, thanks for this work you're doing. I encourage everyone to check out the new book, Super Body. If you haven't checked out the previous books, Wheat Belly, Super Gut, they're all really groundbreaking, seminal works on this. And so thank you for that. And I hope it won't be too long until we have you back on again, because there's always more to explore.
Thanks, guys.
All right. We will make sure all the contact information for Dr. Davis is available in the show notes. This has been Stay Off My Operating Table with Dr. Philip Ovadia. Thanks for joining us. We'll see y'all next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.